Open up the session, I'd like to introduce Dr. Agnelli, who is a professor of medicine at the University of Perugia in Perugia, Italy, to discuss Apixaban for the treatment of venous thromboembolism associated with cancer, the Caravaggio study. Dr. Agnelli.
It's my privilege and honor to present the results of the Caravaggio study. This presentation is made on behalf of the members of the steering committee of Caravaggio. Caravaggio is a study on the treatment of venous thromboembolism in patients with cancer. Patients with cancer and venous thromboembolism have a very high risk of recurrence and bleeding, and this requires specific studies on anticoagulant treatment. The major guidelines recommend almost unanimously the use of low molecular weight heparin, but they have opened to the use of Apixaban and rivaroxaban. However, the clinical benefit of this agent is limited by an increased risk of bleeding in comparison with dalteparin, mainly occurring at the gastrointestinal site. The aim of Caravaggio was to assess whether oral Apixaban would have been non-inferior to dalteparin for the treatment of venous thromboembolism in patients with cancer. Caravaggio was a randomized, open-label, non-inferiority study with blind assessment of all study outcomes. Patients with a confirmed venous thromboembolism, DVT, or pulmonary embolism were randomized to receive Apixaban or dalteparin. The Apixaban regimen was the regimen of the amplified that was validated in patients without cancer. The regimen of dalteparin is the regimen used in the CLOT study. Caravaggio was an investigator-initiated study sponsored by FADOI and coordinated by University of Perugia and supported by an unrestricted grant from Bristol Myers Squibb Pfizer Alliance. Patients with cancer and objectively confirmed venous thromboembolism were included in the study. They had symptomatic or incidental proximal lower limb deep vein thrombosis or symptomatic pulmonary embolism or incidental pulmonary embolism in the segmental or more proximal pulmonary artery. The maximum proportion of patients entering the study with incidental VTE was set at 20% of the overall study period. Patients with any type of cancer, with the exception of basal cell or squamous cell of the skin, primary brain tumor, or non-cerebral metastasis in acute leukemia were included in the study. Patients were categorized as patients with active cancer and history of cancer. Patients with active cancer were those with diagnosis made in the last 6 months or receiving treatment for cancer in the last 6 months, or with a recurrent locally advanced or metastatic cancer. Patients with history of cancer were those not fulfilling the above-mentioned criteria, but with diagnosis made 2 years before the study inclusion. Again, the maximum proportion of patients entering the study with history of cancer was set at 20% of the overall study population. As all the clinical trials in complex clinical setting, also Caravaggio had several exclusion criteria, including age lower than 18 years, life expectancy of less than 6 months, and active bleeding or high risk of bleeding that contraindicates anticoagulant treatment. The study outcomes. The primary study outcome was objectively confirmed recurrent proximal deep vein thrombosis of pulmonary embolism occurring during the study treatment period. This means a proximal deep vein thrombosis of the lower limb, both symptomatic or incidental, deep vein thrombosis of the upper limb, symptomatic, pulmonary embolism, symptomatic or incidental. The major safety criteria was major bleeding that was defined according to the EMA criteria, that means the STH criteria with the addition of bleeding that necessitate acute surgical intervention. The study hypothesis was that Apixaban would be non-inferior to dalteparin for the primary outcome, this is VTE recurrence. We anticipated a rate of recurrence in the control group of 7%, so that with some specified non-inferiority margin and beta and alpha level, we set up a sample size of 1,168 patients. The primary analysis population was the modified intention to treat population. That means all patients that were randomized and received at least one dose of the study drug. Overall, 1,170 patients were randomized and were equally assigned to Apixaban and dalteparin. 15 patients did not receive any dose of the study drug, so that the modified intention to treat population was 776 for Apixaban and 779 for dalteparin. The two treatment populations were comparable. The mean age was 70 years, and the groups were comparable concerning sex and weight. There was a slight prevalence of patients with pulmonary embolism over patients with DVT. The rate of patients with symptomatic venous thromboembolism was 80%. The proportion of patients with active cancer was 97%, and about 60% of patients were on anti-cancer treatment at the time of randomization. Concerning the type of cancer, the most common was colorectal, that was present in about 20% of the patients, followed by lung, breast, and genitourinary. Altogether, about 25% of the patients had the cancer of the gastrointestinal tract, and about 1/3 of the entire population had a cancer in the gastrointestinal system. These are the main results of the study. The primary efficacy outcome, that is VT recurrence. A recurrent VT was observed in 32 patients in the Apixaban group and 47 in the dalteparin group, a rate of 5.6 and 7.9%, corresponding to a 37% risk reduction, a clear demonstration of non-inferiority. The recurrence rate of DVT was 2.3 and 2.6 respectively. For pulmonary embolism, 3.3 and 5.5, a risk reduction of 46%. 4 patients died in the Apixaban group for a fatal P and 3 in the dalteparin group. These are the data concerning safety. Major bleeding was observed in 22 patients in the Apixaban group and 23 in the dalteparin group, corresponding to 3.8 and 4%, a risk reduction of 18%. The rate of major gastrointestinal bleeding was 1.9 in patients receiving Apixaban, 1.7 in patients receiving dalteparin. There was a numerical excess in clinically relevant non-major bleeding in the Apixaban group, 52 patients compared with 35, corresponding to 9.0% versus 0%, a 42% increase. The site of bleeding in this clinically relevant major bleeding was essentially the genitourinary tract and the upper respiratory tract. So again, there was no increase in gastrointestinal bleeding, even when the clinical relevant major bleeding was considered. The composite of major bleeding and clinical relevant major bleeding was 70 in the Apixaban group and 56 in the dalteparin. These slides show you the time curves of the recurrent VT and major bleeding. On the left, you actually see the recurrent VT, and you see that the two curves separated almost about 30 days. Concerning the bleeding, the two curves are almost superimposable. So these are our conclusion. We conclude that oral Apixaban was non-inferior to subcutaneous dalteparin for the treatment of cancer-associated venous thrombosis. We didn't observe any increase in the risk of major bleeding, particularly at the gastrointestinal sites. And we believe that the findings of the Caravaggio expand the proportion of patients with cancer-associated thrombosis who are eligible for the treatment with the direct oral anticoagulant, including patients with gastrointestinal cancer. Before closing, I would like to thank the members of the several committees of the study, including the steering committee members, the data monitoring committee, and the central adjudication committee. And finally, I would like to say that this paper has been published today in the New England Journal of Medicine, so you can see and find more details about this study in this publication. Thank you very much for your attention.
Thank you, Dr. Agnelli, and congratulations on a major study. We'll ask Dr. Key to discuss this and with a follow-up by Dr. Carey. Dr. Key.
Thank you. And I also want to express my congratulations to you, Dr. Agnelli, and to your entire study
Thank you very
team.
much.
Excellent study. Well done and exciting findings. As you state, high need cancer populations suffering from a clinically significant burden of VTE and PE reported to be anywhere likely from 8 to 19%, depending upon tumor type. And I was particularly impressed by the low rate of bleeding, which has been traditionally a concern with DOACs, as well as the demonstration of non-inferiority of Apixaban. I had a series of questions for you, and I'll also, of course, love to have Dr. Carey chime in. But the questions relate to, were there any dose reductions with Apixaban? And also, that's as it relates to the trial itself. Also, a question relating to the trial in terms of the interpretation of what else has been published and what we know from the literature. A much lower bleeding rate compared to studies that have been previously published, like the Kusai BTE study. And why do you think that's so? Is it because of type of DOAC, duration of treatment, differences in the prevalence of upper GI cancers? And then finally, the question relating to clinical implications. In whom shouldn't we be considering Apixaban in now? So, series of questions. I'm happy to repeat them as well.
No, the first question is about the dose reduction. Well, the dose reduction was not allowed during the Caravaggio study. I'm talking about Apixaban. The dose reduction was allowed for dalteparin according to the regimen approved in any of the participating countries. The second point is extremely important. I have to say that in order to make the comparison you are alluding to, you really need to have a head-to-head study with the different agents. And unfortunately, we don't have such studies, but we do have studies where the individual agents were compared with dalteparin. When we see the results, it really looks that the bleeding rate in the Caravaggio study was very low in the Apixaban group. It was consistent in terms of rate in the dalteparin group when compared with the other studies. Mm-hmm. But it is quite well known that there is a reduced gastrointestinal bleeding with Apixaban in AFib. So whether this is related to the drug, the administration twice a day, it's something that can be discussed. But honestly, the final solution would be to have a comparative study. And it's going to be difficult, but that's what we need. The very last point, it was what's about the clinical application of the data in terms of population. Well, I do believe that the data with the Apixaban in the Caravaggio study, they actually extend and the number of patients that could receive the oral agent. I believe this includes patients with GI cancer. So I do believe that this indication about using DOACs in cancer patients could change and the indication could be expanded. Of course, we are building on something that is already known. So we didn't discover all of us, but I think it's some additional information that are important for completing the story.
Great. Dr. Carey, additional thoughts?
Certainly. Well, I'd like to join in congratulating you, Giancarlo, for an outstanding study. And I think this is extremely important because monotherapeutic agents without a previous lead-in course of heparin for DOACs have been limited to pilot studies in the past. And this study, I think, conclusively shows non-inferiority. The question that I have is related to the specific subset of patients with gastrointestinal malignancies and the bleeding rate that occurred there. Could you comment?
Yeah, well, first of all, the number and the proportion of patients with gastrointestinal cancer in Caravaggio was the same, if not slightly higher than the other studies. So we actually have a population that is representative of all the cancer population, including GI cancer. We also have some sub-analysis where we are correlating the site of cancer with the type of bleeding. The full analysis is actually ongoing, but we can anticipate that even in patients with cancer, the rate of GI bleeding, even in patients with GI cancer, the rate of GI bleeding was quite low. And anyhow, was not different between Apixaban and dalteparin. And I believe this is one of the novelty of these studies. That's our opinion. Again, we need the head-to-head studies, as I said before, but I think we have a very nice and remarkable signal that we can expand the proportion of patients with cancer that could take advantage of this very practical treatment. Dalteparin is quite inconvenient for the injection for 6 months, and this is certainly an advancement in terms of practicality.
Thank you.
Fantastic. Thank you, Dr. Agnelli, Dr. Carey, and Dr. Key.